Okay, let's go ahead and get started with the cardiac rhythm review. Our objectives for this presentation are going to be that you're going to understand the 8-step rhythm strip interpretation process, and you'll demonstrate this by recognizing rhythms. We'll start off with electrophysiology. So basically electrophysiology, our EKG, is showing depolarization and repolarization in different areas of the heart. So with atrial depolarization, this is going to be shown through the P wave, followed by a completion of the atrial depolarization with the PR segment. So that is where it meets the isometrical line. Then you'll see a QRS complex, which is showing ventricular depolarization. During this time, the atria will also be repolarizing. The ST segment shows that ventricular depolarization is complete. And then our T wave is going to show that ventricular repolarization is beginning. The return to the isometric line shows ventricular repolarization is now complete. So cardiac conduction occurs through specific nodes, starting off with the SA node, which is in your right atrium. The signal will travel from the SA node over to the AV node. The AV node will then connect to the bundle of His, which will branch off into your left and right bundle branches, and then the bundle branches will continue off into Purkinje fibrillars. So each of these has an intrinsic rate that it usually will go at. The SA node's intrinsic rate is going to be 60 to 100 beats per minute. The rate of the AV and bundle of His is going to be 40 to 60 beats per minute. And then the bundle branches and the Purkinje fibers can fire at a rate of 15 to 40 beats per minute. These will be important later on when we talk about, what if the SA node isn't firing, what if the AV node isn't firing, what will be the normal rates for those. As far as reading rhythms on EKG paper, you have to know what these segments of time are measured in. So on our EKG paper, we have very, very small boxes which measure at 0.04 seconds. 5 of those boxes will be 0.2 seconds. 5 of those boxes will be 1 second. And then usually on a strip, we will have a 6-second period. So it's very important for you to know for your test. So here we have, this is not a 6-second strip. This is just showing what the waves are going to look like and what these intervals are, how we measure these intervals. So the P wave and the PR segment come together to form the PR interval. So the PR interval starts at the beginning of the P wave and ends at the beginning of the QRS complex. It's very confusing because it's called the PR interval, so you would think you measure it from the P wave to the R wave, but you do not actually. You measure it from the beginning of the P wave to the beginning of the QRS, and this should normally be 0.12 seconds to 0.2 seconds. These intervals are also very important for you to know for your exam. Following that, we have our QRS complex, which is normally going to be 0.08 seconds to 0.12 seconds. And then we have our ST segment, and we have our QT interval. QT interval should be less than or equal to 0.44 seconds. Outside of that, a period of time longer than that is going to be a prolonged QT. So this next slide is just a review of what we talked about thus far. We have our P wave, our QRS, our T wave. It's important for you to understand what each of these waveforms mean. Going into further about our QT interval, we've talked about how our QT interval is measured from the beginning of the QRS to the end of the T wave, and this represents total ventricular activity in the heart. A prolonged QT interval has a variety of causes and can be very serious, as it may lead to potentially fatal arrhythmias, such as polymorphic VTAC. Certain medications, electrolyte abnormalities, and disease states can prolong our QT. Whenever you're measuring calipers on our EKG machine, you're going to get a QT result, but you're also going to get a QTC. The QTC is the QT interval corrected for a heart rate of 60. So you should be writing what your QT interval is, but just know that your QTC is what if that same rhythm was going at 60 beats per minute. What would your QTC be? So as we've said before, prolonged QT intervals can lead to fatal ventricular arrhythmias, such as polymorphic VTAC and torsades. Some causes are listed here below. Some that I'd like to point out include amiodarone. We give amiodarone all the time for arrhythmias because it will decrease the ventricular rate of multiple tachycardic rhythms. Another medication that we give a lot is Seroquel and Haldol. Those are both antipsychotics. We give Seroquel to patients who have ICU delirium at night to make them go to sleep. And then we can give Haldol IV push, and that's just an antipsychotic that we can give, like say if Ativan isn't doing the trick, we can always go for some Haldol. So those are just some meds that I'd like to point out. They can prolong your QT interval. Going a little bit more into some EKG changes and stuff we want to be assessing is we want to be assessing every rhythm for myocardial infarction. So this can be either as a STEMI with ST elevation. ST elevation is going to start being measured at the J point, which is the upward stroke of the T wave, and it should be greater than 0.2 millivolts, so it's going to be more than or equal to 5 of those small boxes, and you can see that in the top right EKG shown below. But you can also have ST depression or T-wave inversion that's going to show some myocardial infarction changes. And this is going to be when you have a downward slope of your ST or you have your inverted T-wave. So those can be shown in the middle at the bottom with your T-wave inverted. All of these changes you want to make sure, if they're acute, to be letting your physicians know. So now let's talk through this 8-step rhythm determination. The first step is going to be seeing if the rhythm is regular, so looking at your RR waves and determining is the distance the same throughout our entire strip. The next step is to look at the atrial rate and the ventricular rate and determine if they're normal, and also determine if they're the same. So atrial rate is going to be determined by how many P waves we have, and our ventricular rate is going to be determined by how many QRS complexes we have. So ideally, the atrial rate and the ventricular rate are the same, such as in sinus rhythm, you have every P wave has a QRS, every QRS has a P wave. So on a 6-second strip, the atrial rate and the ventricular rate are going to be the same. These rates, though, can differ if you say, if you by chance maybe have a AFib or a flutter, your atrial rate and your ventricular rates are going to be very different. But also say if you have an AV block, certain AV blocks you're going to have more P waves than QRSs. The next step is going to see, does the P wave look normal? Do they all look normal on the entire strip? And do they all precede a QRS complex? Step 4 is looking at the PR interval and determining if it's normal. So remember, a normal PR interval is 0.12 seconds to 0.2 seconds. Step 5 is looking at the QRS complexes and determining, do they all look the same? Are they normal looking? Do you have ST elevation? Anything like that. Step 6 is the QT interval. Is it a normal length? Is it prolonged? Step 7, is there anything else unusual? Any kind of ectopy or premature beats occurring? ST elevation, etc. Step 8 is then putting all those things together to name the rhythm. So now let's talk about rate a little bit. You can determine the rate of the heart rate by counting the number of QRS complexes and multiplying it by 10, since we have 6-second strips and there's 60 seconds in 1 minute, and we're measuring heart rate by beats per minute. We can just count the number of QRS complexes, multiply that by 10, and that's going to be our rate. So here we have 7 QRS complexes, so here our heart rate would be around 70. It's not going to give you the exact rate, but it will get you pretty dang close. So go ahead and practice with this strip and calculating the rate using that method. There definitely are other methods to calculating rate Whenever you are doing your calipers, it's something that you just want to double check, is making sure that your rate is close to what you would calculate using this method. Let's go ahead and start off with sinus rhythms. With sinus rhythms, the impulse is always going to be originating from the SA node, which we talked about has an intrinsic rate of 60 to 100 beats per minute. So in normal sinus rhythm, the P wave is going to look normal in size and shape. Your PR interval will be normal, QRS will be normal, our rate is going to be 60 to 100, rhythm will be regular, this is not life-threatening, and this is a normal finding. So this is what we want all our patients to be, but most of the time they aren't. Sinus bradycardia, you will have a normal looking P wave, a normal PR interval, a normal QRS, but your rate's going to be less than 60 beats per minute. Your rhythm should be regular though, and depending on the cause it can be life-threatening. So some causes of bradycardia are going to be vagal tone, calcium channel blockers, Precedex infusions, DIG, lithium, beta blockers, antidepressants. So if the patient's sleeping, don't freak out if they're bradycardic. We're really only going to treat bradycardia if it's normal. So although you're not going to be tested on treatments of the rhythms on your rhythm exam, we're going to touch on those options throughout this presentation. So like I said, only treat sinus bradycardia if it's symptomatic. This will be if your patient's experiencing chest pain, signs, symptoms of heart failure or hypotension. And we could treat bradycardia with medications called chronotropic drugs, which basically means they increase heart rate. These are examples like dopamine, epi, atropine, all those medications increase heart rate. So this can either be through IV push, like with atropine, or it can be an IV infusion with dopamine or epi. We can also treat bradycardia by placing a pacemaker. If you need to do this emergently, we will transcutaneously pace with the pacer pads and with the life pack, which you will learn how to do whenever you're doing your ACLS. Patients can also get transvenous pacemakers or permanent pacemakers if needed, and we will talk about pacers a little bit later on in this presentation. So with sinus tachycardia, we have a normal P wave, normal QRS, normal PR interval. Our rate will be greater than 100, which is usually going to be in between 100 and 150. After a rate of 150, this may actually not be sinus tach. It will likely be another kind of rhythm we'll talk about later. The rhythm is going to be regular though. It's not usually life-threatening, but it's definitely something that you want to fix. Some causes are going to be caffeine, anxiety, pain, hypotension, exercise, heart failure, hypoxia, volume depletion, fever, drugs, or hypotension. So really, our treatment's going to be finding the cause and treating it off of that. So if it's pain, giving pain medication. If it's anxiety, turning down the lights, decreasing the noise, or maybe having to give some anti-anxiety medications. If it's fever, we can cool the patient with ice or put them on a cooling blanket. We can always give them Tylenol. And if they're dehydrated and hypotensive, we can always give them an IV bolus. Continuing on with atrial rhythms, the atrial rhythms impulses will originate in the atria rather than in the SA node. So the first atrial arrhythmia we're going to talk about is a flutter. So with a flutter, you're going to have sawtooth looking P waves. The PR interval, there will not be one because there's not just one P wave, there's multiple of them. Our QRS is going to be normal, and our atrial rate can range anywhere between 250 to 400. So this is an example of where our atrial rate is going to be different than our ventricular rate. So on here, if we count the number of QRS complexes, that's 1, 2, 3, 4, 5, 6, 7. So our rate would be 70, but our atrial rate is going to be a lot higher. The rhythm can either be regular or irregular. So on this strip, you see 3 or 4, depending on, honestly, this is computer generated. They're not going to look like this all the time. But here you can see 4 P waves to 1 QRS. So this would be a 4-to-1 ratio. So you can put that in your EKG interpretation documentation. So they may be regular, they may not. You may only see 2 P waves and then a QRS, or you may see 4 like in here. Depending on the ventricular rate, you may have to give an antiarrhythmic such as amiodarone or cardizem, and you can also do a synchronized cardioversion or an ablation. These are obviously going to be more invasive with their own risks and benefits for the patient. Cardioversions we can do at bedside. Ablations we don't do at this hospital, but we can send them to Texan or to Maine. With AFib, the P waves are going to look wavy, unidentifiable. The PR interval, there will not be one because there's no distinct one P wave for every QRS. QRS complex is going to be normal. Atrial rate will always be pretty much greater than 400. Our rhythm will be irregular. It may be very close, but it won't really ever be regular. And by that I mean the RR intervals, so from one QRS complex to another, is going to be slightly different each time. Depending on the ventricular rate, this can say if it's life-threatening or not. So if you have a very high ventricular rate, then basically what's happening is you're having all of these atrial firing complexes occurring. So you have all these P waves happening, and the AV node, remember, is what is holding that signal there before it travels down the middle of the heart and over to the ventricle. So with the rapid rate, what's basically happening is that AV node is just letting all of these atrial signals go through. And this will result in a higher ventricular rate. So when we have a higher ventricular rate, we call this RVR, which stands for rapid ventricular rate. And so this will occur in patients, and we'll call this AFib RVR. So we can give antiarrhythmics like amiodarone, cardizem, as I said before. Usually, though, we want to make sure to find the cause and treat off of that. So a lot of times our patients here will go into AFib RVR if they're septic, if they're hypoxic, and so we want to kind of find the cause first. But we'll usually be putting them on one of these drips. Difference between amiodarone and cardizem is amiodarone is going to be a lot better on your blood pressure than cardizem. Cardizem will usually drastically lower the blood pressure, and then you'll have to stop the drip, and then you'll have an arrhythmia again because you're not getting your antiarrhythmics. But ablations are essentially just finding where that signal is coming from and, essentially like damaging it so that way it doesn't fire and send off signals inappropriately. Next, we see atrial pause. Atrial pause looks like sinus rhythm, but basically an entire PQRST complex drops. Your PR interval is going to be normal. QRS will be normal, but our atrial rate is going to be slow, just because some beats are missing, and your rhythm will be irregular, and this can be life-threatening because essentially atrial pauses can just stay asystole. So the patient may need a pacemaker, and just because this can lead to life-threatening situations. Junctional rhythms. So with junctional rhythms, the impulse is originating near or within the AV node versus the SA node. So when we talked about those intrinsic rates, we said that our SA node has an intrinsic rate of 60 to 100. Rather, AV node is going to have an intrinsic rate of 40 to 60. So when we talk about the speed of those rhythms, just like we talked about with sinus rhythms, you have sinus Brady if it's less than 60, and it's sinus tach if it's greater than 100. These things are going to differ with junctional because the normal intrinsic rate is a lot lower than sinus. So with junctional rhythm, P waves are either going to be before, during, or after the QRS complex, or they're going to be completely absent. And that's just because the impulse is going to travel up the atria and down the ventricles, and so this will result in the inverted P waves. And this can happen, like I said, prior to, during, or after the QRS complex, or it could just not be there. So like in the first strip that you see, there is no P wave, but in the second one you see the P waves inverted. So your PR interval will be normal, QRS will be normal. The rate is going to be slower, 40 to 60. Life-threatening, it depends on the ventricular rate really. And then causes are the electrical impulse isn't arriving from the SA node, it's arriving from the AV node because the SA node essentially isn't firing. So with accelerated junctional, pretty much everything is the same that I've already said, except your rate is going to be 60 to 100. So if I were to look at this strip, this is not a sinus rhythm. This is a junctional rhythm, but because of the rate, it's an accelerated junctional rhythm. So it's somewhere between 60 and 100 beats. Some causes of accelerated junctional can be dystoxicity or damage to the AV node. With junctional tachycardia, everything like I said prior to will be the same, except your rhythm is going to be greater than 100, or your rate is going to be greater than 100. It can be life-threatening depending on the ventricular rate, and some causes are going to be caffeine, hypoxia, CHF, mitral valve disease, fatigue, or altered pacemaker in the heart. Ventricular rhythms. Impulses are going to originate in the ventricles. With VTAC, the characteristics, you're not going to have a P wave. You're not going to have a measurable PR interval. Your QRS is going to be very wide and bizarre looking. The rate is usually going to be very, very fast. The rhythm, though, will be regular. This is a very life-threatening arrhythmia, and some causes are going to be MI, hypoxia, hypotension, ischemia, acidosis, phenytoin, DIG toxicity, altered potassium, and MAC levels. So VTAC can either have a pulse or it can be pulseless. So the first thing you should do if your patient is having VTAC is determine if they have a pulse. This is going to determine your treatment for the patient. So if the person has VTAC with a pulse, you still want to act quickly, as this can only happen for so long before your patient becomes pulseless. So treatment for VTAC with a pulse includes giving an antiarrhythmic such as amiodarone. You can do a synchronized cardioversion. But it's important to find the cause. So most likely with our population, it's going to be due to hypoxia, acidosis, or low potassium issues. But if your person did have an MI, they may start having VTAC. Treatment for VTAC without a pulse is to initiate ACLS protocol, and this is a shockable rhythm, so you're going to probably defibrillate as soon as possible. So on the next slide, you see there are different kinds of VTAC outside of with a pulse or without a pulse. They can be monomorphic, like in the top strip, or they can be polymorphic in the bottom. Basically, you're just going to have different looking waveforms. Following that, though, you can also have VTAC progress into torsades, or torsades progress into VTAC or VFib. So with torsades, it does look different. It can be confused with VFib, but VFib, we'll see in a little bit, is going to look pretty different than this. So whenever you're, interpreting your rhythms, this is pretty much what torsades is going to look like the entire time. It's a specific form of polymorphic VTAC, and this usually happens with patients who have a long QT interval. It's characterized by rapid irregular QRS complexes which appear to be twisting around the ECG baseline. This arrhythmia can cease spontaneously or degenerate into VFib. And the treatment for torsades is going to be an IV MAG infusion. Moving on, we'll talk about SVT. SVT, you're going to have pointed or hidden. P waves will be pointed or hidden in the T wave. PR interval is going to be pretty immeasurable. QRS will be normal. The rate is going to be 150 to 250. So this is what we talked about with the sinus tachycardia, how I was saying, like, normally sinus tachycardia is only 100 to 150, and then after that you're kind of like, is it SVT? Is it not? It's usually going to be SVT, so you should do a EKG, a 12 lead. But if you don't see P waves, then it's SVT. The difference too between SVT and AFib RVR is SVT is going to be pretty regular. AFib RVR is not going to be regular, and you'll even see it on the monitor. Like your heart rate will go from like 140s to 160s to 150s with AFib RVR, but with SVT it's just going to be like the same rate. It'll be like 180, 199, 200, whatever. It'll be regular. And this can be life-threatening depending on that rate and how long the patient can tolerate it for. Causes can be caffeine, hypoxia, CHF, mitral valve disease, fatigue, or altered pacemaker in the heart. So treatment for SVT is going to be to give an antiarrhythmic that will decrease the ventricular rate such as amiodarone, like we've talked about before. You can also give adenosine, which is widely known as a medication that will stop and restart your heart. So this medication, though, is pushed very quickly, and it has to be flushed rapidly because it has a very quick half-life. But usually, if your patient's in SVT and you give adenosine, they will likely go asystole just for a hot sec, but because of that quick half-life, all you gotta do is do a few compressions and it will cycle out a majority of the time. Unless your person has like severe acidosis or severe hypoxia, this will be something like, it'll cycle out, hopefully. Hopefully it does. Moving on, let's talk about paroxysmal SVT. So the difference here is that the rapid rhythm starts and then stops suddenly. So here we see this person's in a sinus rhythm and then they have sudden onset of SVT. So this is called paroxysmal. So you can have paroxysmal SVT, you can have paroxysmal AFib, you can have paroxysmal AFib RVR. It just basically means your rhythm is normal and then it just busts into this rhythm and then it comes out of it. So for that reason, it's pretty hard to, fix because you don't have anything that's sustained long enough for you to fix it. But yes, this is paroxysmal SVT. Moving on, let's talk about VFib. So VFib, notice the differences between the VFib and the VTAC that we've talked about. VFib is going to be, a little bit more compact. The rhythm is very irregular, it varies in shape and size. But it usually it can follow PVCs or VTAC, and it's the most common cause of sudden death. Treatment for VFib is to initiate ACLS protocol, and this is a shockable rhythm, so you're likely going to defibrillate early on. Moving on, asystole. So asystole, there's nothing there. You don't have a pulse. And it's going to follow VFib or VTAC. It can be due to altered potassium levels, severe acidosis, hypothermia, hypoxia, or drug overdose. On the strip on the right, you can see P waves, but there's no QRS. So this can be called ventricular standstill. It's the same thing as asystole. There's no QRS, so there's no ventricular activity, so you don't have a heartbeat. Even if your atrial are beating, if you don't have your ventricles beating, you're not going to have any delivery out of the heart, and you will eventually have completely asystole. This is not a shockable rhythm. I don't care what Gray's Anatomy says. So initiate chest compressions and administer epi. Idioventricular rhythms. Idioventricular rhythms are going to be initiated by the bundle branches or the Purkinje fibers. These have a slower rate than the AV node and the SA node. So the intrinsic rate for the AV node is 40 to 60. The intrinsic rate for the SA node is 60 to 100. So the rate is a lot slower here, and the rate will be 20 to 40. So yes, there will usually not be a P wave. You won't be a PR interval. Your QRS is going to be very wide. Rate's going to be pretty slow. Rhythm, though, will be irregular, and yes, this is life-threatening. This is usually going to occur after an acute MI or with DIG toxicity, and so you want to very much treat this. You may have to do a pacemaker. You may have to give them atropine. You may have to end up utilizing ACLS protocol for this. So let's talk a little bit about now ectopic beats. So ectopic beats essentially happen when the cells away from your heart's own natural pacemaker get a little excited and they release an electrical signal causing an early or extra beat. So we'll talk about PACs, PVCs, and PJCs. So PACs are premature atrial contractions. So with premature atrial contractions, you're going to see there is a P wave, but they're going to look different than what your other P waves look like. So if you look at your strip, the P waves of the PAC are a little shorter, like in length and height. So they do look a little bit different, and that's just because they're coming from a different place. Your QRS will be normal. And your rate with people who have PACs is going to be the rate of the underlying rhythm. So because they have a premature atrial contraction, it's usually going to continue on, and they have a QRS and a T. So this will just look like an extra early beat whenever you're looking on your rhythm. Now, if you're looking and you see all of these earlier extra beats, what you want to think about is, okay, is this actually sinus arrhythmia? So sinus arrhythmia is just when it's sinus, but there isn't a distinct rhythm between the Q, but there isn't a distinct length between the R waves. Every P wave has a QRS, every QRS has a P wave, the P waves always look the same. That's going to be sinus arrhythmia. PACs are going to be when you just have a premature beat and the P waves will look different. So this can be because of coffee, alcohol, emotionalness, T, CHF, fatigue, fever, hypoxia, or mitral valve disease. Premature ventricular contractions. You will not have a P wave with these beats. There will not be a PR interval. Your QRS is going to be wide and bizarre looking. The rate is going to be dependent on the underlying rhythm. Rhythm is going to be irregular due to the premature beat, and it can lead into some worsening arrhythmias like VTAC if you have multiple PVCs. Causes can be ventricular irritability, low calcium, anxiety, hypoxia, MI, altered potassium, or ditch toxicity. So talking a little bit more about PVCs, if you'll hear terms like couplet, you'll hear terms like bigeminy, trigeminy, so we're going to talk over those a little bit. So a couplet is when you have two PVCs in a row. This is a couple of PVCs, so it's called a couplet. Bigeminy is going to be when you have a normal sinus beat followed by a PVC, followed by a normal sinus beat, followed by a PVC. So essentially the second beat is a PVC. If you have trigeminy, as you can guess, this will be when the third beat is a PVC. So you have two sinus rhythms followed by a PVC, followed by two more sinus rhythms, followed by a PVC. So the third beat is going to be a PVC. How many times can I say PVC in this slide? But yes, so PVCs can look a little differently, like how you see on the right strip on the bottom here. The PVCs can look one way, they can look another, just depending on where exactly they're coming from. Continuing on. Premature junctional contractions basically look like a junctional beat. There will be an inverted P wave. It can occur before, during, or after the QRS complex, or it can just not be there at all. PR interval will be normal, or actually pretty small. QRS will be normal. The rate is going to be whatever the underlying rhythm is, and the PJC makes it irregular. It's not really life-threatening. Causes can be vagal tone, alcohol, potassium levels, altered stress, heart failure, caffeine, ditch toxicity. Moving on, bundle branch blocks. So bundle branch blocks are when one of the bundle branches, either the left or the right, has a blockage. So essentially there's delayed conduction on one side of the heart. This is going to cause a wider QRS complex. So it will be greater than 0.12 seconds. This is why it's important to check your calipers. Just because you have every P wave has a QRS doesn't mean that you have a normal sinus rhythm. You can have a bundle branch block, and it can either be on the left or the right. So how you determine that is on our 7 lead that we have on all of our patients, you can see V1. You cannot see V6. So in order to see V6, you would have to get a 12 lead. But we can always see V1 on all of our patients. So if you go to V1, if you see that the QRS complex is, the peak of it is facing down, it's going to be a left. So how I remember that is down low is a left bundle branch block. Up right, so when the peak is upwards, it's going to be a right bundle branch block. So that's just how you can determine them. So with left bundle branch blocks, essentially, like I said, your QRS is going to be widened. Rhythm is going to be supraventricular in origin. Life-threatening, the main complication of bundle branch blocks, right or left, is that they can progress into a complete heart block. And this can slow your heart rate, which can cause fainting and lead to serious complications and abnormal heart rhythms. So causes of bundle branch blocks are going to be aortic stenosis, extensive coronary artery disease, dilated cardiomyopathy, long-standing hypertension leading to aortic redilation, acute MI, Lyme disease. With right bundle branch blocks, the underlying rhythm usually is going to originate in the atria. The main complication of the bundle branch block, again, as we said, is it can slow your heart rate and it can cause serious complications just going along with that. Causes can be right ventricular hypertrophy, PE, cardiomyopathy, congenital heart disease, rheumatic heart disease, hypertension, Brugada syndrome, or myocarditis. Now let's go into heart blocks. So with heart blocks, the impulse from the top to the bottom of the heart is delayed or interrupted. We'll go ahead and start off with our first degree AV block. So the rule with the first degree is that your PR interval is prolonged. It's greater than 0.12 seconds. If you have a PR interval greater than 0.2 seconds, then you have a first degree AV block. Causes, this is the first sign of increased AV blocks. It can stay like this or it can progress into a worsening block, which we'll start talking about now. Degree AV blocks, there are two types. Type 1 is also known as Winky block, because he's the guy who made this up, essentially. But essentially what you're going to see is the PR interval is going to progressively prolong, and then you're going to have a P wave and no QRS. So causes will be acute inferior MIs, vagal stimulation, ditch toxicity, conduction system disease. But the rule is if you see your PR interval getting longer and longer and longer, and then you have a QRS drop, then that's a Winky block. And there's a lot of like riddles, stories, stuff that you can look up to remember the blocks. So I know for the Winky block one, it's longer, longer, longer drop. That is a Winky block. But yes, you can look all that stuff up. It's very cute. Continuing on, you have your type 2. So with your type 2, the rule is that you will have P waves and you will have QRSs. Some P waves will be followed by a QRS. Some of them will not be followed by a QRS. But if you have a P-QRS complex, the PR interval is going to be the same across the board. So again, you'll have P waves, you'll have QRSs. Some of the P waves may have a QRS, some of them won't. But if they do, the PR interval will be the same. Causes of this can be bundle branch blocks, lesions of the conduction system, anterior MIs. Continuing on. Third degree AV blocks basically mean that there's P waves and there are QRSs, but they have no relation to another. They're just basically doing their own thing, beating whenever the heck they want, and it's not good because it usually results in a bradycardic rhythm. If the person becomes symptomatic of this can be a big life-threatening emergency. Is usually going to follow an acute MI, DIG, or potassium toxicity, ischemic heart disease. And so treatment for this is going to be giving some atropine to increase the heart rate, but if that doesn't work, we may have to do transcutaneous pacing. And if we do that, then we'll need to either get a transvenous pacemaker or permanent pacemaker. But if the patient comes in and they're in a third degree AV block and they're chilling, and they're not having any, symptomatic or symptoms, then we can kind of wait on it. We'll just watch for the symptoms. If they occur, then we can always do the drugs and the transcutaneous pacing. But if not, then, we admit them, we do cardiac monitoring, we make sure they're all good, and then they get a pacemaker sooner rather than later. But it may, if they come in overnight, it may not be until the next day that they get the pacemaker. So let's talk about pacing. So pacemakers are programmed in the following way. They are able to sense conduction through the heart, and that sensing will either inhibit or trigger the pacemaker, or it can do both. And this is similar to your positive and negative feedback loops that you learned about in nursing school. So a beat can either inhibit or they can trigger the pacemaker to fire, or it can do both. So the pacemaker does sense if a chamber is going to beat or not, and then it will fire certain chambers. So you have the first, basically you'll have multiple letters on a pacemaker to tell you what the mode is. So you'll have DDD pacemaker, which means that both chambers are paced, both chambers are sensed, and both beating and not beating will inhibit or trigger the pacemaker. So This can be a little bit difficult to understand at the very beginning, so I tell people, like, don't worry if you don't understand the modes of pacemakers. Just know that, you know, they just sense certain chambers, they respond to sensing in a specific way, and they pace certain chambers. Usually the most common pacer we're going to see are DDD chambers or DDD pacemakers, but we can also see VVD pacemakers as well, so ventricular pacing and stuff like that. So on the next slide we see the chambers pace. So here, if it's an atrial pacemaker, you're going to see a pacer spike followed by a P wave, and usually then because of the P wave there will be a QRST complex. So this is a atrial paced pacemaker. Under that you have a ventricular paced pacemaker, which means that you may have, like here on that bottom lead, I don't know if it's artifact or not, but they have, you know, a few different looking P waves, and so the pacemaker then fires at a specific rate and a QRS complex follows that. So this is ventricularly paced. On this next slide, you see that this is a dual pace pacemaker. So you see two pacer spikes. First pacer spike's gonna cause there to be a P wave, and the next pacer spark will cause there to be a QRS complex. With anytime the ventricles are paced using a pacemaker, they're gonna pop off these funky looking QRS complexes. It's not bad, it's just what happens because of the pacemaker. So if you don't see pacer spikes on your monitor and you see, you know, QRS complexes looking all kind of funky, then and you know your patient has a pacemaker but you don't see the pacer spikes but the QRS complexes look funky like this, your monitor is just probably not picking them up, so you have to go alter your monitor settings. But it is very important that you see pacer spikes when you have a pacemaker, because that's going to show if you're having problems with your pacemaker. So let's go over some of those a little bit. You have failure to pace, so this is when the pacer is not firing when it's supposed to. So on this strip you see, you know, pacer spike, QRST, this is a ventricularly paced pacemaker, and then it should beat but it doesn't, and it just takes its time, and then you see a pacer spike followed by a QRS, another one, and another one. So this is failure to pace. There's no pacer spikes, so therefore there's no rhythm. Very scary. Failure to capture is when the pacer is firing, but we don't see a rhythm following the pacemaker. So this can be because either the tissue is hypoxic, you're acidotic, your cardiac cells are like dead. If you have like an MI or something, the cells are dead. There's nothing to pace, you know, that can happen. But it can also be because your amplitude on the pacemaker isn't high enough for there to be conduction. So on this strip you see multiple pacer spikes, but only some of them are having what we call capture. They're having actual conduction activity. Finally, you have problems with sensing. Your pacemaker can either oversense or it can undersense. Undersense is when the pacemaker fails to detect spontaneous myocardial depolarization. So you see pacer spikes despite there being P waves and QRS complexes. This is not cool because essentially if the heart is getting electrical activity from the pacemaker in the wrong spot, then you can have arrhythmias. So if you have a pacer spike on the T wave, you can essentially have, you know, ventricular arrhythmias, because this is when the heart is not supposed to be getting any kind of electrical activity. This is ventricular repolarization during this time. It's not supposed to be messed with. So undersensing is not cool. Oversensing occurs when electrical signals are inappropriately recognized as native cardiac activity, and the pacing is therefore inhibited. So the pacemaker basically thinks like, oh, these T waves are actually QRS complexes, so I don't need a fire. So that happens a lot. So when you have peak T waves in a pacemaker, your pacemaker can then think, oh, those are QRS complexes, I'm not going to fire, and then it's just wrong.
So this brings us to the end of the cardiac rhythm review. If you have any questions about this presentation, please let me know or ask a hospital educator. And I hope this presentation helped you out, and I'll see you in the next video. Thanks for watching.